Intensive care unit is like an atom bomb. We spend significant amount of time with the family, patient family, explaining them the pros, cons, and this happens every day. We at least spend 8 to 10 minutes with every family. For this, we call it as a disaster management system. We have a very, very strong disaster management system in our hospital. COVID-19 pandemic was devastating. We would look at all the 60 patients and then enter into the intensive care unit with all the level 3 suits. It is horrible to do the rounds. 3 to 4 hours, 60 patients. It was unbelievable. Her kids, 2 kids had passed away, 1 son-in-law, 1 daughter-in-law, her sister had passed away. She would tell me that I am going to an empty home. I don't want to go anywhere. Why did you save me?
ICU. Does that ring a bell in your head? It surely should. Today we have Dr. Arjun Alva, who lives his life day in and day out of ICU. Welcome, sir, to Healthcare Off the Clock.
Thank you.
First of all, I want to tell you that you can be at ease. This will be a candid conversation between you and me. I just want to know the different aspects of your life as an intensivist, in hospital, beyond the hospital, and what are your takes on multiple facets of being in the healthcare industry. So I'll start with the first thing that might sound very boring to you, but I just want to gain an insight in how do you start your day or your shift when you are entering the ICU, because you handle 2-3 ICUs at one time. So It must be very difficult. So how do you plan that?
So intensive care unit or the ICU can be very, very busy in the night. It can be very stressful, especially for the night doctors and the nurses. So the aim of the intensivist, first thing in the morning, is to make sure that the nurses and the doctors leave the hospital premises as soon as possible. So the first thing that we do is reach the hospital by 8:30 in the morning and take a quick handover. It can be quite detailed handover, but it should be a quick handover so that we can finish it off within an hour and a half. So by 10 o'clock, most of the time, we allow the doctors and the nurses to go back home. When I'm talking about detailed handover, so for example, we have a 60-bedded intensive care unit, and we have 5 to 6 intensivists in the morning. So each intensivist will have about 10 patients to take care of. So in that 1.5 hours, we look at everything about that patient for that 1 hour in a concise manner, saying that the doctor who was there in the night would tell us about the events that happened in the night. Once that is done, we take a quick, probably a coffee break, and then the doctors who are there would again do a detailed rounds of the patients, and we will tag along with them and we will give the plan for the day.
Yeah. Very typical of me, but still want to have an insight on how does a day of an intensivist looks like?
Intensive care unit is like an atom bomb. It can explode any time. We spend about 9 to 10 hours at workplace. So it is non-stop. We come to work either at 8, 8:30 or 9. And from 9 to probably 11:30, 12, we are looking at, again, examining the patient, looking at their lab reports, plan for the day. And the most important bit in our intensive care unit is the counseling, because the patient family is not allowed to be inside the intensive care unit. So since the patient counseling is the most important thing, and we make it a point that every patient family is spoken to every day. Okay. So 9 to 12 will be the clinical work, 12 to 1:30 is usually the counseling bit, and then we come back again and we follow up on the plan for the day. We see if all the work that has been discussed in the morning rounds, has it been done or not. Okay, so that takes another hour. So that's the second round of rounds that we do. Okay. And then that follows up with going and seeing if anybody else need any help if we are free. Okay, and then every shift for doctors in the intensive care unit, again, an important aspect is handing over. So if I'm working 9 hours or 10 hours, if I'm working from 9 to 6 p.m., so there will be a doctor who will be there at 6 p.m., a consultant. So we will be giving a handover to the consultant of all the 10 patients that I have planned for. In our ICU, the whole intensive care unit is 24/7 monitored by a senior consultant. probably 14 to 16 hours in person in the unit, and rest of the time, again, we are fortunate enough to have an application which will help us to monitor the patient and do rounds of the patient remotely staying at our house.
Okay. So I've been in situations where I've taken my father to hospitals in emergency, and he required the ICU bed at that time.
Yeah.
So I understand the bed is not in control. Number of beds is not
Yeah.
in control of the hospital. Definitely, I mean that is a constraint. I mean, looking at the population of India, but how do you decide the urgency level of care that a patient would need in an ICU?
Intensive care unit is usually divided into 3 levels of care. Level 1 care, where we have patients on minimal oxygen who require advanced nursing monitoring but does not require invasive monitoring. So these are the patients who we would keep for 6 to 9 hours, monitor them and see if we need to be kept in the ICU or can they be managed in the wards. So then we have level 2 care. Level 2 care is where the patients require a single organ support. So when I'm talking about single organ support, if the patient has got pneumonia, unable to breathe, so we put the patient on a ventilator.
Okay.
Single organ. The rest of the organs, that is the heart, the kidneys, the liver, they are working fine. Okay, so it needs single organ support, again, invasive monitoring. Here, this patient needs to stay in the intensive care unit. Okay, but when we come to the level 3 care, is the sickest in the unit. So level 3 patients are always seen first by me. If I'm coming in the morning, once the handover is done, the first patient who I would concentrate is this level 3 patient. Who is level 3 patient? Level 3 patient is somebody who has got more than 2 organs, which is being supported and monitored. Yeah. So the patient is ventilated, the patient is on a ventilator, his blood pressures are not maintaining, so I'm supporting his blood pressure with medication. His kidneys are not working, so I'm supporting it with dialysis. So more than 2 organs are being supported, and that is how we triage the patients. For example, our average waiting period in our emergency room, okay, is about 4 hours. Yeah. This is shifting from the ER to the intensive care unit. But in the recent past, we've not had patients waiting outside our ER. Okay. If something like that happens, we make sure that we arrange the ambulance and we send them to the closest intensive care unit. So we have that communication with the emergency medicine doctors in the other hospital or intensive care doctors with other hospitals. So for us, patient care comes first, and we make sure that is looked after.
Yeah, I think that's a big point of relief for all the patients and their families.
Yeah.
Because people do come to hospital only in urgent cases.
Yes.
And if that sort of thing is there, then
yes,
it becomes extremely easy and comfortable for them.
Yes.
So while I understand that ICU doctors and nurses are always on the roll, and there isn't always a situation there, but let's say there's a bomb explosion that might have happened.
Okay.
Right? And few people have been, they require that urgent emergency care, and maybe not only bomb scare, but there can be situations where a lot of people got infected with some disease like COVID.
Or polytrauma, major accident.
Yeah, major accident. Yeah. So how do you tackle such critical situations? I mean, and respond, and how do your team prepare and respond to that sudden critical situation? So
for this, we call it as a disaster management system. So we have a very strong disaster management system in our hospital. For example, Narayana Health is JCI accredited, NABH accredited. We've got all the accreditation, and we also have these disaster management team. So for preparation for such cases, once in 6 months or once in a year, we have drills. We do mock drills where we create these life scenarios of polytrauma. Like for example, 30 people are injured and they're all coming in an ambulance, and how well we are prepared, the preparedness. So we conduct these preparedness programs, these mock drills, which helps us to get ready with all the beds. Again, here triaging is very, very important. So we work on triaging. The emergency room and the intensive care team, they work in tandem, they speak to each other. Along with that, it's a big team. The disaster management team is a big team. It's not only the doctors, it is the administrator, the finance teams, the ambulance crew, the security officers. Everybody is, is prepared for this kind of a situation. At least in our hospital, we have these drills which help us in preparing for these instances.
I think that's pretty proactive.
Yeah.
I think that really helps to assess the situation way better. And definitely a lot of lives are saved because of that. So now we talk about the interventions of tech across the board,
Yes.
like across sectors, right? And the maximum tech as a commoner that I've seen in the hospital is that monitor and the maximum, the revenue cycle or revenue billing management system. I just wanted to know from your lens, because you must be using a lot of softwares, right? So what role does health tech solutions play in ICU, and how do they aid in patient management and care?
Narayana Health is probably blessed to have a lot of software application. NH has coordinated with Atma team, and they've given us a beautiful system, a phone-based application which is called Adi. Adi is like it's a digital marvel for us. We come to the hospital, we are driving to the hospital, we're sitting at home, we know everything that's happening to the patient. We know their blood investigations, it's integrated with the radiology. So it's very, very handy for us. So Adi has made our life very, very simple. Okay. Adi also has a lot of integration with artificial intelligence, which gives risk scoreboard as well, which has helped in better documentation. We are typing and using voice recording, which the AI in the Adi converts and makes the documentation more clearer and more easier, which at the end of the day is helping in better quality care for the patient. For example, I've been waiting here to come and speak to you. Meanwhile, I received a call from one of my colleagues saying, how is this patient, the patient which we did a procedure in the morning. So I just picked up my phone, looked at the Adi, looked at the progress notes, looked at the lab investigations, and me being 20 kilometers away from the hospital, I could exactly tell my colleague what was happening with that patient.
Okay.
So that is something that technology has helped me and most of my colleagues at work. Along with this EMR, which is very, very helpful, one more advantage of this EMR is, again, ours is a multi-specialty hospital. Okay, and one patient is seen by almost 4 or 5 different departments. So it becomes, so instead of me opening the records and turning the pages to see what the neurologist has written, what the hepatologist has written, or what the pulmonologist has written. Instead, I am driving to work or I'm somewhere having a coffee. I can just look at the electronic medical records and just swipe and see that, okay, this is what the other multi-specialty doctors have written. And then I can directly have a conversation with my multi-specialty colleague and come to a plan. Okay, it's making our life much easier.
So you told me that we are still at a very nascent stage in adopting the tech in healthcare.
Yeah.
Right. And if I recall, or if I have to talk about the time when COVID happened, so between 19 to 2021, what was it like there?
Yeah.
And how do you used to handle so many cases?
Yeah.
Because tech was still getting developed. People or doctors, or even for hospital administration, tech was a very alien concept at that time.
Yes.
So what really was going through in Narayana Health facilities, and what was really going through in ICUs that were handled by you?
COVID-19 pandemic was devastating for all of us. It was a pandemic. It caused mayhem across the globe. We were a group of 4 or 5 ICU consultants, and we were looking after 30-bedded intensive care unit. Suddenly, the surge was so much that suddenly 60 to 70 beds were occupied. We converted the wards into intensive care units. But it needed some specialists to look after it, and specialists were us, we intensivists. We stayed in the hospitals for 7 days, 24/7. Fortunately for us, the vision of our chairman, even before the pandemic started, our chairman had this vision of having IT in healthcare. Although it was in its initial stages, once the COVID happened, we very quickly realized in order to manage so many patients, we need help. And that is when Adi helped us. So that was the time when we went full-fledged. We were in the hospital 24/7. We were in our rooms. We would look at all the 60 patients, okay, and then enter into the intensive care unit with all the level 3 suits. It is horrible to do the rounds, you know. It would take about 3 to 4 hours, 60 patients doing procedures. It was unbelievable. But for us, our work, which we would do for 4 to 5 hours without the Adi, now with the help of the Adi, we had reduced the time to almost 1.5 hours, 2 hours. So our 40 to 50% of our time was reduced. We were less tired and we could be more efficient.
So before even proceeding for the next question, I would like to thank doctors like you who made the COVID situation easy for us. It wasn't that easy, but you tried your level best, and hats off to you and your community that really served the nation pretty well.
Thank you.
Yeah. And moving on from the COVID surge, so a bit on the other side of the ICU now. So I have experienced myself, and I'll speak from my experience only. So once my father got admitted to the ICU as well, and that was my first experience. Prior to that, I had never been to any hospital, and you have only like an hour or so to meet the patient, and beyond that, you're always in anxiety, you know, to what is happening inside, and is he well enough? And even in the night, you cannot go inside. And I mean, there are multiple things. So I used to have sleepless nights. So I was very anxious throughout it. So I just want to know, like, because the tech has made life so better for you. So is there anything that you have done for families as well? Like, how do you ensure that families are informed about the patient's health, about the patient vitals, so that they are not anxious at all, so they are a little more relaxed than they are not? So is there any system like that in the place right now? So
in our intensive care units, family counseling is the most important part of our tick box, if you want to listen to it. We spend significant amount of time with the family, patient family, explaining them the pros, cons, and this happens every day. We at least spend 8 to 10 minutes try to spend 8 to 10 minutes with every family. That is in person. Out of hours, if some of the anxious patients, they do request these phone calls, or they do request wanting to visit the intensive care units. Although it's very difficult to encourage and give permissions to every family, we also give permissions to our nurses to make video calls, so that the patient, the patient family can see the patient. Along with that, the application, the phone application Adi, which I was talking about, has this option where you sitting at home can give an update about the patient on the application itself. So the message will go loud and clear to the family, saying, he's stable, he's unstable, or he's doing well, he's pain-free, he's comfortable. We give those kind of informations to them.
Yeah, I think it's very comforting to know this. Like I am pretty sure a lot of hospitals are doing it, but I haven't heard of it till now. So to everyone out there, I think hospitals should start using such thought processes and such mechanism.
It's helped us a lot, and it has made our patients' family members less anxious because of this application.
So you've been managing the ICUs since long now. You see lives getting back on track, to people succumbing to their injuries, their medical issues. So, what dilemmas do you come across on a daily basis while managing such critically ill patients?
I want to touch upon two very important topics which we intensive care doctors sometimes struggle with. One is organ donation, and second one is end of life care. It is a big dilemma. It's big dilemma, very difficult for many of the doctors find it difficult to speak to the family regarding organ donation.
Yeah.
Okay, because some of the families think that when we talk about organ donation, they think about organ donation rackets.
Yeah.
They talk, because we've seen so much in the media about, kidney rackets. It's very, very unfortunate. In fact, August 12th was an organ donation day. And across the country, many NGOs, many hospitals, media are all working towards improving the organ donation awareness. We have hundreds and thousands of people waiting to get new organs. Patients with end organ damages, might be kidneys, hearts, liver, young patients, people of different ages. I would just like to give two examples. Okay, one is a young 3.5-year-old, which very recently happened in our hospital. A young 3.5-year-old kid with a brain tumor, operated, ended up having brainstem death. Brainstem death is basically a clinical death. Brainstem is an organ which controls the respiration, the heart, the movement of the hands and legs, hearing, listening, seeing, all of it. So when there's a brainstem death, means the patient is clinically died. And that is when we discuss about organ donation. Okay. So here was a 3.5-year-old boy whose parents had very recently were involved in organ donation awareness program, and they said, we want to donate the organs of this young kid. And because of that, 4 other kids in the country got organs, and they could probably live for many years. So organ donation is like reincarnation. The organs that is given to other people, so they live with them. So they can live a new life, longer life in different people. The message that I want to give here is, I would want everybody in each household to think about organ donation when such event happens.
Absolutely. I think giving life to the other,
yes,
it's a very, I would say, a very courageous step as well.
Yeah.
And we should understand, the organ donation only happens when there is absolutely no possibility of resurrection of the patient.
Yeah.
So yeah, that's also the clarity that I wanted to give to the audience.
Sure.
That it only happens once that everyone is assured multiple times.
Yes.
That we can't bring back the real life of the patient.
Yes.
Yeah.
And the second topic which I wanted to discuss was end of life care. Quickly, there is a term called euthanasia.
Yeah.
Yeah. So when we discuss about end of life care, people think we are doing euthanasia. Again, there are a lot of legal. There is no clarity. There is a lot of, even now we have a lot of people are not clear about what is the legal standpoint. Even us, we find it difficult to discuss about end of life care. But there are few terms called as withdrawal of therapy. Okay, withholding the therapy.
Yeah.
Okay. Again, I would like to give a couple of examples here. Like, for example, somebody who is an 85-year-old with poor quality of life, who has come to the hospital with a stroke, ended up on a mechanical ventilation because, everybody wants to do the best for their family members.
Yeah.
Okay. So this gentleman was on a mechanical ventilator with a stroke. And then we sat down with the family, we discussed with the family of what are the next options. So one of the option which which an intensivist gave the family member was, okay, we understand the quality of life, so we should not be troubling our family member too much. So let's not stop everything, okay, but let us not give more organ support. Okay, and therefore we reduced the support, made sure that he's comfortable, and in the presence of the family, with their consent, we made sure that he passed away peacefully. Okay, that is one option. Second option was the similar patient. Some other families, they would want to continue therapy, and we as doctors can give the therapy for the kidneys, for the heart, for the lungs, okay, and we can extend their life as much as we can. So again, end of life care is also a difficult topic, and again, it is something that we need to keep learning and keep speaking to the family members so that we can help for a better quality of life.
It's been quite a big career for you, and there have been moments, at least in starting, if I would have to ask, that must have shook you, from down under. And you are in an ICU, you see situations day in and day out. So what is that one situation that you still remember till date that kind of gave you the first shock in healthcare?
There have been many situations which has emotionally shook me a lot. There's one particular incident which I can remember. It's about a school teacher, probably in her late 60s. So we did struggle a lot to get her better. She had COVID pneumonia, ARDS. This was during the pandemic. She had a COVID pneumonia, bad acute respiratory distress syndrome. She was in the intensive care unit for a couple of weeks. And then she got better. She was discharged from the intensive care unit to the ward. And she was somebody who was very, very difficult for us. We never thought she would make it. But then she survived and went to the ward. And so I was in the hospital. It was my turn to do the COVID duties, and I finished my ICU rounds. And I heard that Mrs. X, who was going home. So I went to her, saying, wishing her good luck, etc. And I said, you were very, it is very nice to see you going home. Please take care of yourself and all the very best. And she was completely unimpressed with me. She was very, very upset with me. She said, "Doctor, why did you save me?" And she started crying. And then I got to know that her entire family had passed away because of COVID. Her kids, 2 kids had passed away, one son-in-law, one daughter-in-law, her sister had passed away. And her husband had passed away even before she got COVID. So she would tell me that I am going to an empty home. I don't want to go anywhere. Why did you save me? Those were her words. So that was very, very disturbing for us.
That's an extremely painful story. From moving on from extremely negative to somewhat positive. So I'm sure there must be patients which have been full of life that really inspires you a lot. So one story about that as well.
So I can probably, same timeline, COVID pandemic time. So there was a young girl, 19, 20-year-old. Again, my duty, just going through, and she was very, very young. And she was, we did a lot of what is called as prone ventilation. People would, we would connect them to a ventilator and make them sleep on the tummy. So this young girl, her lungs were very stiff, and to get her better, we had to do about 8 to 10 prone ventilations, which was at that time we thought was overkill, or usually at the end of four prone ventilation, if they did not improve, we would say, okay, very, very unlikely to survive. So this was a person who was a fighter. Who, after 9 prones, she got better. She, had a tracheostomy, had a tube in her neck, and again stayed for three weeks and got better and went home. When she was going home, she said, "Sir, thank you very much for helping me." And she said, I will promise you that I will become a doctor and I'll try to save more and more people." And then one fine day she comes to me and says, after a year or year and a half, she comes to us and says, I've got so much in so and so rank, and I've passed in my NEET, and I'm going to join the medical school and going to become a doctor. So that was very fulfilling for us. I really felt nice about it. Yeah.
I think these are one of those moments that remain with your life.
It does.
Like your efforts finally paid off.
Yes. Yeah. The two extreme, isn't it?
Yeah, absolutely.
It's the same era, two different people, and a good story and a bad story.
Yeah. So at NH or Narayana Health facilities, we're already seeing a lot of technical implementations, and through your words, I get to understand that we are already kind of living in a much better space. So what is your vision of a future hospital, let's say 20 or 30 years down the lane?
The future hospitals will be at your home. From my perspective, post-COVID, what we've realized is we need intensive care beds for critically unwell patients. I personally feel that in future, the patients would come to the hospital would be mainly because they are having a elective operation or an emergency surgeries, or they are very, very unwell that they need to come to the intensive care unit. Patients who are mild to moderately sick might be able to manage at home with online consultations, and probably that would be how our future hospitals will be. More than 60% of the hospital beds will be filled by only critically unwell patients.
I wanted to know one more aspect about your life. So, again, deriving it from my personal experience, I was an engineer, then I did an MBA, and I'm now working in healthcare. So, how did that transition happen for you? Like, I'm pretty sure nobody thinks to be an intensivist while they are approaching their MBBS.
Yeah.
So, is there a story to this?
I am an intensivist by chance.
Yeah.
I wanted to be an engineer, but my mum almost forced me to become a doctor. She said something like, "Look at Dr. Devi Shetty. Look at what great surgeon he is. Look at what great doctor he is. You need to become like Dr. Devi Shetty." These were the words that she said in the year 1999. And my father, he said that if you get into medical school, I'll buy you a car. So that was a barter which my dad played with me. So my mom's emotions and my dad's, my dad giving me the thing that I'll give you a car, that made me join medical school. And I thought I'll become Dr. Devi Shetty at the end of 4 years, which of
and
course.
Look at the destiny, now you're working with Dr. Shetty.
Absolutely. And I'm so proud, and my mom is so proud that I work in Dr. Devi Shetty's organization.
With that, we wrap up this episode of Healthcare Off the Clock. Hope you would have had a great time watching Dr. Arjun Alva and gaining insights from his experience. Thanks a lot, sir. Thank you so much for providing us your insights.
Thank you.
All that you could impart us with.
The pleasure was mine. Please like, share, and subscribe Healthcare Off the Clock.